First, you must know what are all the sources of cyanide. One is smoke inhalation. Other is cryogenic glycosides like amygdalin, which are present in some foodstuffs like almond, apricot, and prune species. And hydrogenically, when we use SNP, sodium nitroprusside, to control hypertensive crisis, prolonged use of sodium nitroprusside can result in the accumulation of cyanide in the body and lead to cyanide toxicity. And industrial exposure to these things can also produce this problem. Then industrial solvents and cosmetic remover like nail polish remover or lipstick remover, all these things also contain this, so you have to be very careful. And chemical warfare with again, biological warfare is another question that has been asked in your papers repeatedly. So this is one of the chemical which is used for biological warfare. And poison from rodenticide, animal control, alternative medicines from apricot kernels. So all these are the sources. And sometimes the fumigant in airplanes and buildings and ships, these also contain cyanide. The mechanism of toxicity binds with the ferric ion of cytochrome oxidase enzyme, which causes this particular terminology you should use in your answer. It causes histotoxic hypoxia and lactic acidosis by affecting the mitochondrial oxidative phosphorylation. Stimulates biogenic amine release, causing pulmonary and coronary vasoconstriction, which results in pulmonary edema or heart failure. And then stimulates neurotransmitter release like NMDA, causing neurotoxicity and seizures. And the volume of distribution is about 1.5 liters per kg, and it is highly protein bound, and the elimination half-life is 2 to 3 hours. And symptoms of blood cyanide concentration requires, as she said, 40 moles per liter. Detoxification is by an enzyme called rhodanase found in the liver and muscle. And thiosulfate serves as a sulfur donor in the reaction catalyzed by rhodanase that converts cyanide to thiocyanate. And the main routes of elimination, these four routes you should remember. Very small quantities will be eliminated in urine, sweat, and breath. And by the enzymatic reaction, what we described here from the liver and muscle, the rhodanase enzyme, by adding sulfur to the cyanide, converts it into what is called thiocyanate. Then aldehyde and ketone functions, they can be produce a stable non-toxic compound. But the main mechanism is hydroxycobalamin converting this into cyanocobalamin, producing a stable non-toxic compound which can be removed by the kidney. And physical findings are patient can inhalation or and within a few minutes of cyanide ingestion. The clinical manifestations can be divided into early and late. Early symptoms, as she said, headache, dizziness, confusion, mydriasis, and tissue hypoxia, which causes seizures and coma, or it can be a direct neural irritation also.
Sir, excuse me, sir.
Huh?
Your slide sharing stopped suddenly.
Oh, yeah. So late findings include apnea, hypotension, and cardiac arrhythmia. Patients with cyanide poisoning will not be cyanotic. This is a very important thing because the oxygen utilization at the mitochondrial level is blocked. So the venous blood returning has a higher percentage of oxygen compared to the normal person. So the blood has got a cherry red color. So there will be no cyanosis in this patient. That is a very important clinical finding. And investigations, as she said, you can do all the complete blood count, urine analysis, urine toxic screen, and ABG is very, very important to find out the amount of lactate that is produced because of the non-utilization of the oxygen. and the plasma lactate level will be greater than 8 millimole, 90%, which is 94% sensitive and 70% specific. And all patients rescued from domestic fires, you have to think of both cyanide toxicity and carbon monoxide, and consider obtaining acetaminophen and salicylate levels also to rule out co-ingestions, which also can give a similar picture. And an increased anion gut metabolic acidosis is expected. The treatment is stabilize the patient's airway breathing circulation. Mouth-to-mouth respiration should be avoided. Decontamination is also a vital. Single dose activated charcoal can be given if cyanide has been taken by oral route. Antidotes, these are the available antidotes: amyl nitrate, sodium nitrate, sodium thiosulfate, and hydroxycobalamin. This is crushed and inhaled, induces methemoglobinemia via oxidation to bind the cyanide. So methemoglobin is able to attract the cyanide and convert it into methcyan hemoglobin, and that route it will be easily reduced. And sodium nitrate also given in the form of 300 milligram, 10 ml, 3% solution, given intravenously 3 to 5 minutes, which also induces methemoglobin formation. And sodium thiosulfate is called hypo. The other name for sodium thiosulfate is hypo, which is available as 12.5 grams given in 50 ml as over a period of 30 minutes, combines with unbound cyanide to form thiocyanate and excreted, and hydroxycobalamin combines again with unbound cyanide to form the cyanocobalamin. And the recent introduction in this is the liposomal methemoglobin. They have now come out with this for especially for delayed to prevent delayed effect of unused or unabsorbed cyanide in the body to be converted. So you have what is called encapsulation of methemoglobin with lipids. Which other drug is available as a liposomal preparation?
Sir, amphotericin B.
Amphotericin B.
Amphotericin B.
Amphotericin as an anesthetist.
So even local anesthetics are.
Which local anesthetic and why they have introduced that liposomal preparation? Bupivacaine, liposomal bupivacaine. Okay, that is
Yes.
given for patients with chronic and intractable pain because it will have a longer duration of action. Okay, so the same principle is used here. And how does hydrocobalamin is an antidote? Seems to be the ideal cyanide antidote. It has a rapid onset of action, neutralizes cyanide without interfering with the cellular oxygen use. That is the most important advantage of that compared to the other two. Tolerability and safety profiles are good and conducive to pre-hospital use. You can use it even while transporting the patient, and safe for use with smoke inhalation victims, and it is not harmful when it is given to adult patients and easy to administer. And the main cyanide are other the cyanide binders are cobalt containing drugs like dicobalt editate and hydroxycobalamin, and then sulfur donors like thiosulfate, which we have already seen. Then methemoglobin generators, oxidants such as amyl nitrate, sodium nitrate, and dimethyl amphophenol convert hemoglobin, that is ferrous form, to ferric form, which binds to cyanide, forming cyanic hemoglobin. And the 2 points about this dicobalt etidate is it is administered as a 300 milligram IV, 7.5 mg per kg over 1 minute in the 50% glucose, repeated up to 3 times if an immediate clinical response is not seen. This cobalt salt is toxic, so it can by itself cause seizures, chest pain, dyspnea, head and neck swelling, hypotension. So this, due to this toxicity, is only reserved for severe cyanide poisoning, which does not respond to the usual treatment of sodium nitrate and other conditions. Okay, so these are the points that you have to, 2 more or 3 more points extra that I have told what some Hiranmayi presented are the liposomal methylglobin and these individual characteristics of hydroxycobalamin and its safety, and the dicobalt editate, which you can add to the answer, make it complete. Okay.
Yes, sir.